Hi, this is Mrs. White, and this lecture focuses on understanding urinary incontinence. Now, we will be looking at this through NextGen, as we usually do, including recognizing and analyzing the cues, prioritizing our hypothesis, generating solutions, taking action, and we have a little spot for medications to know, as well as relevant diagnostics. So I just want to focus in on here for just a minute. Forgive me as I'm learning how to do this system here. I actually just wrote in on that. But so first and foremost, we're going to talk about the different types of urinary incontinence. And there's technically 5 different types. So let's go through the pictures that we have here and I'll explain. The most common type is going to be stress incontinence, and that is due to increased intra-abdominal pressure. So that's why we get that one. And the reasons for that, I mean, again, most common, it's a weakened pelvic floor. Things like pregnancy, trauma, menopause. So that's probably why it's one of the most common. I'm sorry, the most common. So urge incontinence is a sudden urge to void, and that is often called overactive bladder. So that's that commercial, gotta go, gotta go, gotta go right now. And then overflow incontinence is what happens when the bladder gets too full. Okay, it's too full, so we see spillage of urine. This can be seen in things like acute urinary retention, BPH, spinal cord injuries. And this one can be a little tricky because the person may actually have urine output that is, if we're not astute to realize that their intake and output is not equal, we can basically miss this one. I have oftentimes the men just keep dribbling. They have the urge to go, they can't go, but they're peeing only very small amounts. So this one often will have a palpable bladder, especially as the urinary overflow becomes just too much. So that's that one. And then there's functional incontinence, which for us, functional incontinence is due to physical or cognitive issues. One of the most common is dementia, but it can also happen for people who are unable to take care of the needs. Imagine if this person had buttons all the way down here. They're using a cane. They have trouble getting out of bed, so the bed alarm is going off, and the bathroom is pretty far away. So that is functional incontinence, physical or cognitive, which is pretty interesting because all of us were functionally incontinent at one time, weren't we? So let's come over here. I'm just going to erase my little notes there. Actually, I'm not going to erase them. I'm going to bring us over here now, and we're going to go ahead and try and recognize and analyze some of the cues. So number one sign and symptom we're going to see is involuntary loss of urine. And I'm sorry, I just want to go back one thing. I said there was 5 types of urinary incontinence. The last one is called mixed, which is a combination of any of the 2 most common stress and urge incontinence together. So mixed urinary incontinence. So that's the last one. So back over. What are we going to see? Involuntary loss of urine. I mean, that's pretty much a hallmark. However, it can be in the case of overflow incontinence that we may not have any urine output, but that's its own separate lecture. So involuntary loss of urine. For stress, because of the intra-abdominal pressure, that's often happens when we increase intra-abdominal pressure, coughing, laughing. So that would be stress. Overflow, small frequent urination, and urge incontinence, the person is constantly have to go. So some other things that we may see as part of urinary incontinence that we may not actually tag as incontinence, but it's definitely something you might see, okay? Especially if somebody's managing their incontinence, is changes in their mood. So anhedonia, that's basically a symptom of depression. They might be withdrawing from social activities. There's a lot that can happen, but honestly, we don't have to go too much further into that. So let's, the other thing I will mention is that a person sometimes will have frequent UTIs. And that makes sense, right? As we may not be emptying the bladder completely, we have urinary stasis, and that can lead to some problems. All right, so let's go down to relevant diagnostics. All right, so relevant diagnostics are really focused on ruling out UTIs and urinary retention. So one of the common things we'll do is a bladder scan. So that is non-invasive, basically a little ultrasound of the bladder to check post-void residual, so PVR, post-void residual. This is making sure that the bladder is emptying. We may do a urinalysis, just looking for potential issues with infection. So a UA can show possible infection. We can do bladder stress tests, urodynamic studies, basically all aimed at trying to figure out the cause of the urinary incontinence so that we can then work on treating it. So urodynamic studies are usually done in a doctor's office. They often require an insertion of a catheter and instilling fluid into the bladder to see the patient's response and how well the bladder empties. So it's the most common. And then based on that, we can diagnose the type of bladder incontinence. Let's going to take a moment and come on over to prioritizing hypothesis. All right, so we've moved on over here on my screen. So what are some of the things that you can think of that could be a result of urinary incontinence? Of course, infection. And that could be UTIs, but then let's also look at the potential for skin breakdown. We don't want urine sitting on the person's skin. So skin breakdown, which can lead to maceration. It can also lead to skin infections. And then, of course, social anxiety. That's probably one of the things that people complain of a lot to me, is that, they just can't go anywhere. They're always embarrassed. And so there's things that we can do about this. Now, let's just take a step back, though, and remember that a person may think that they're just incontinent, and they have like this perceived incontinence, when it can really be acute urinary retention and overflow incontinence, which the treatment's just a little different, right? So we're going to go over and take a look at what can we do. Let me see if I can move you over here without having to go crazy. All right, so we're going to generate solutions. We're going to take action. So let's start with some of the common things. Pelvic floor muscle disorder. So stress incontinence, we could do something like Kegels. Kegel exercises. All the ladies should be familiar with that if you've had a child. So that's pelvic floor. So that strengthens the pelvic floor, and that's a series of exercises that the person can do. Overflow incontinence, there's some things we can do for that. So we could do something called the Crede maneuver, and that helps empty the bladder for overflow. We might be able to do catheterization, and that could be intermittent, or it can be indwelling. All depends on the patient and what's happening. The one thing that I'll mention, it's kind of interesting, in the hospital we always do catheterization as absolutely sterile procedure, but many folks that are at home, they're doing a clean procedure for intermittent. Just something to note. I used to have a patient that would actually drop his catheter in the toilet, and the decision was finally made that this patient was not able to manage self-cath at home, and so they ended up with a indwelling Foley catheter. It was actually better for them. All right, functional incontinence. Let's look at some of the things that we can do. And I want you to really think about your nursing home patients. And we kind of do this with our young children, too, sometimes, because they are often functionally incontinent, right? We make changes to their clothes. We make sure that they're easy on, easy off. We might make sure that the room has a clear line to the bathroom and that they have their walkers and etc. at the bedside so that they can reach them and that they can use them. So we might do things like making sure the toilet paper in the bathroom is set up in such a way that the person who's using adaptive equipment can get in and use the bathroom. We might even do scheduled toileting. Now that can work for many of the types of incontinence, so scheduled toileting. Functional, right, because it will keep them going to the bathroom with assistance, and also for urgent incontinence, it's sort of like a bladder training. One of the things I do want to mention is there is a safety concern with some incontinence, especially if the person has nocturia, and that is the risk for falls, right? Many of our falls that occur for people who are hospitalized actually occur related to bathroom use, or just trying to get out of bed and trying to go fast because they just have to go. So there's that, and there's also the impaired sleep, which can happen for that. We want to assess the patient. We want to assess their baseline, and then we want to be able to compare it to what we see after our interventions. Because if somebody's, let's say, for example, they have neurogenic bladder, we can't really expect they're going to be continent, right? We might say that they're better, so we want to know where they're at. And then sometimes, yes, we can absolutely say that incontinence is taken care of based on our treatments. And that the patient endorses a better quality of life, that the skin is intact, that the patient hasn't suffered any falls, and that they have no UTIs. So those are going to be some of our important evaluations. So coming back to overflow, because that's its own special animal, some of the things that we can do for it, of course, would be the catheter. We talked about that. And it's based at the cause. So if somebody has like BPH, they might need a TURP. Other things we can do, pelvic floor, person might benefit from a pessary to help lift the bladder up for a pelvic organ prolapse. And some of the things that also decrease stress, intra-abdominal stress, is to decrease your weight, right? Patient might be able to participate in some weight loss. And just remembering that people who have increased weights can actually have worse outcomes for urinary incontinence. So that's what we'll get there. And then let's go down to some of the medications. Let's see if I can scroll down here. Oh, yes, we can. Beautiful. So some of the medications to know, estrogen, especially intravaginal. Because some of the risk factors for incontinence is that the person's an older female. When we lose estrogen as females, we get older, that can affect our pelvic floor. It can the increased dryness, and it definitely can affect urination as a result of that. So intravaginal estrogen cream can be used. Duloxetine and Sudafed and Sufedrin, sometimes those are used for urinary incontinence as well. But one of the meds that I really think we should know are basically considered the urinary antispasmodics. So urinary antispasmodics, and of which the most common one is oxybutynin, that you'll see a lot. Oxybutynin. I think that's how it's spelled. Something tells me it's not. Something tells me it's with an I. Name brand for oxybutynin is Detrol. And that's the one that you were familiar with the song, Gotta Go, Gotta Go, Gotta Go Right Now. So, no, I did spell it right. Oxybutynin. Okay, so that is a urinary antispasmodic which relaxes the detrusor muscle. So it inhibits the parasympathetic nervous system. And so it's used in urge incontinence, overactive bladder. Sometimes we use it in UTIs. People have injuries. We can give it by mouth or topical for a lot of them. So Detrol, oxybutynin. I'm sorry, Detrol is not oxybutynin. Let me go back there. Detrol is tolterodine, and we don't use that as much. I must be showing my age. Tolterodine. We use this one is Ditropan. So go ahead and correct that in your notes. So side effects, because these meds are anticholinergic, so they dry you out. So often we're told that they can't see. So dry eyes, blurriness, dry mouth. Can't pee. Can dry out too much, cause urinary retention. Can't spit, right? That's the dry mouth. And can't poop. So constipation. So those are the main side effects of anticholinergics in general. So there are some reasons we shouldn't use Ditropan and the other meds, and those are usually due to urinary obstruction, hypertension that is uncontrolled, cardiovascular disease. Use very cautiously. Narrow angle glaucoma. Narrow angle glaucoma. And also myasthenia gravis. Those people should not be taking this med. You might see people with hypertension. Remember, that's never not an absolute contraindication, but the doctor would have to go ahead and assess the patient for the risk versus benefit and what could happen. And of course, meds to know. Let's take a little nod and remember that sometimes our patients get UTIs, so you might need antibiotics to treat UTIs. And as I'm thinking about constipation, we want to make sure that the person with urinary incontinence isn't constipated as well, because that can lead to increased problems for them emptying their bladders completely. So what do we do to keep somebody not constipated? We'll often do stool softeners, increased activity, things of that nature. All right, so let me close this out for a minute and we'll take a look at the whole thing. Okay, so here of urinary incontinence, and I hope it helps you.